Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor of the series here at Elsevier, and for our 14th podcast, we will focus on the August 2024 issue on endocrine surgery. As the editors write in their preface, this issue serves as an update and summary of the key diagnostic, management, treatment, and outcome considerations for endocrine surgical diseases. Here to discuss these updates with 4 articles out of 17 from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editors of the endocrine surgery issue, Dr. Jessica McMullen, assistant professor in the Department of Surgery at the University of Utah in Salt Lake City, Utah, and Dr. Andrea Gillis, assistant professor in the Department of Surgery at the University of Alabama at Birmingham in Birmingham, Alabama. Welcome to all 3 of you, and over to you, Dr. Martin.
Thanks, John. And thank you, Dr. Gillis and Dr. McMullen, for all the work you've done on this issue. I think longtime listeners of the podcast and even longer time readers of the series sometimes realize, but sometimes don't, just how much work and time goes into getting to the final project, frequently between a year and a half total. So we really appreciate everything that you and your colleagues have done. As John mentioned, you're welcome. As John mentioned, 4 articles have been selected out of the 17, although I certainly encourage the readers to read all of them cover to cover. It's always in their best interest. And for those taking boards, etc., this is yet another good example of something that if you know this stuff, your board's examiners shouldn't give you a hard time. And hopefully they won't. But I would like to start off with the article on adrenal incidentalomas. In my former life as a professor and program director, this was one that we hit the residents with all the time. And I think it really sets us up well to look at just the global approach to endocrine surgery. So this is a paper written by Doctors Hu, Kasu, Techanji, and Kabibu. And if I mispronounce any of their names, I apologize. But so, Andrea, starting with you, why don't you just let's begin with that. The incidentalomas, by definition, are found when you're not looking for endocrine problems. Okay, with very few exceptions. And that generally speaking, they're found by some sort of imaging done for some other reason. So you must get a ton of referrals because somebody got a CAT scan for a kidney stone or something else, and suddenly they find something in what they believe to be an adrenal gland, and somebody wants to call you up rather than work it through. So what's your approach when you get the phone call?
Yeah, I think you're right. There's been an epidemic of these adrenal incidentalomas, everyone going through CAT scans for a variety of reasons. I think the key is to have a set algorithm and do it the same way every time so you never forget anything, especially when you're studying and you don't want to miss anything. So starting with the biochemical test. So every adrenal incidentaloma needs a biochemical test. Even if the radiologists say totally benign, it's not a cancer, it doesn't need anything, as long as it's a centimeter or greater, go ahead and get the biochemical testing. And so I think that is probably the number one thing that everyone needs to take away is that, everyone warrants a biochemical test, even if it seems like the patient has no symptoms and it looks benign on imaging.
I think this brings up a point that I used to stress with my residents, and you tell me if it's still worth stressing. But particularly when it comes to endocrine organs, the first thing you got to decide is, are you dealing with something structural or are you dealing with something functional? Mm-hmm. And as you're alluding to, the functional piece of this is no matter what, you got to sort that out first and then decide if you don't like the structural piece. Is that still fair advice for folks?
Yeah, I think that's definitely fair. Of course, if it looks very suspicious on imaging, and we can talk about that, then you have to go down that pathway as well. And so I think the great thing about this chapter by WHO and the co-authors is that they do divide things up and they give you this nice flow sheet to be able to go down both pathways. So suspicious imaging features versus positive biochemical testing.
When you get somebody sent, say you get a 2 centimeter incidentally found left adrenal abnormality on plain CT done for whatever. Somebody came in with belly pain, they thought they had appendicitis or something. So at least they have contrast on board. It's not a non-con study. So what is your base level workup? Because there's some variety in themes here, I guess, and approaches. So what would you recommend to people?
Yeah, so I would get them into clinic as long as I'm seeing them as an outpatient and kind of do multiple things at once. So I know they're going to get a CT adrenal protocol, a 3-phase CT, because that's the only way to tell the washout characteristics. So oftentimes patients will get these non-contrasted or even just arterially contrasted phase scans, and then you'll get the report saying that the adrenal nodule is indeterminate. And that sounds really scary to people, but it's just because, our hands are kind of tied if there's not the multiple phases. We can't say what type of adrenal mass it is. So they're going to get that CAT scan probably the same day they see me. And then I'll see them, talk to them about kind of their symptoms. So certain patients don't need all of the biochemical evaluation. So if there's no hypertension, you really don't need to test for aldosterone. But in terms of just like the shotgun panel to order for everyone with an adrenal incidentalloma, you're testing all the layers of the adrenal gland. So the cortisol test, my usual go-to is a midnight salivary cortisol. The metanephrine test, the go-to is plasma, and the aldo and renin if the patient warrants it. And so you have that just in your back pocket, ready to go for any patient with these adrenal nodules.
Now, would you do the repeat imaging prior to doing any of the biochemical tests? Or if somebody were traveling to see you from some distance, would you recommend they get some baseline chemical tests done before they come to see you?
Yeah, I get that a lot. So yeah, they can get their tests done locally at like their local lab distributor, and then you really need to go to a high volume center to get a nice CT adrenal protocol. Not every center even does them. So if they can go ahead and get their labs done before they come to see me for their CAT scan, that's even better.
Yeah, I've spent a lot more of my life in the pancreatic biliary world, but I have, as you described, I want the imaging, if possible, if I want specialized imaging, to be done at a place and by people who I know that I can go and look at the imaging and understand what it really means. Not because I think a lot of people are way happier to just keep scat scanning folks, whereas they're going to send the reference lab work out, most of them, I think.
Yeah.
So let's say that let's talk about, at least there is some, I guess, variety as to how people can do whichever. You said midnight salivary cortisol, but for people that are doing dexamethasone suppression testing, which is probably, I think, more common for most run-of-the-mill folk. I don't mean to say that in a negative way, but people that don't do this every day for a living.
Yeah.
I know that there's a handful of people that would be admitted or be tested in certain places. So what's your thoughts on suppression testing?
Yeah, I love the dex suppression test, especially if I already know where they're going to be. So if I know they have like a colonoscopy coming up, or I know they're going to be, in town for whatever reason, or they're going to see somebody in the morning, it's just the logistics can be kind of a pain, but it's definitely a better test. So they have to fill their prescription for the 1 milligram dexamethasone the night before, actually take it, and then go somewhere first thing in the morning and get both the dexamethasone test and the cortisol test. And all three of those things happening successfully usually requires a bit of counseling. That's hard to do if I've never met the person before.
Sure.
But definitely the better test. And the salivary cortisol won't tell you something really important, which is if they have mild autonomous cortisol secretion or max. It just gives you a yes, no. but doesn't really qualify the level of excess cortisol secretion. So yes, love a DEX suppression test.
I mean, certainly the big question with any of these adrenal lesions is, are they functional or are they malignant? Right? Those are the two go-tos to start thinking about making things go away. Now, every boards examiner on the planet, every former professor type, every active professor type, I'll leave you guys in the mix, is always grilling folks on FIOs. So what would you say the percentage of these incidental tumors is likely to turn out to be an actual FIO?
Yeah, it used to be like the rule of tens, I think. It was like 10% are FIOs, 10% are malignant, 10% are genetic. Now that's kind of all out of the window. We know FIOs are really rare, but if you do have them, they are very commonly genetically based. So basically, everyone with a FIO needs to get germline mutation testing for the susceptible gene. But yeah, so the metanephrines will guide you. We get a lot of referrals for just like a 1.5 times or 2 times upper limit of normal metanephrines. Real FIOs are usually 3, 4, 5 times upper limit of normal. There's usually not a tough difficulty diagnosing these. But if there is any question, you can do the 24-hour urine, which can serve as a confirmatory test, and or a dotatate, which is a super expensive confirmatory test, especially if you have bilateral nodules. But yeah, there's those classic imaging findings. The MRI, really bright on T2 weighted images. Again, we usually don't get MRIs, but that's a nice like test question that you will often see. And really bright on CAT scan at that initial phase.
Yeah, that was going to be my next question for you was how often do you turn to MR or PET CT? Because in my experience, we rarely got to the point where we needed them.
Yeah, it's pretty rare. MR mostly for like end-stage renal people or people who are about to become end-stage renal and you don't want to push them over,
Sure.
or like really young people for screening purposes. But I don't get a ton of MRIs.
Okay. Well, I think this kind of lends us into the next topic that I wanted to talk about with Jessica on the small papillary thyroid cancers by the article by Doctors Fields, Underwood, and Pitt. And I think it continues the theme of there are structural problems and there are functional problems. And so, I mean, I think thyroid disease in general, and I worked at Leahy Clinic earlier in my life, and those guys were thyroid mavens, as were the Mayo brothers, of course. And, obviously the goiter belt was a little more popular in the Midwest before you could iodize salt and move fish around, but those days I think are long since gone. There's probably still some iodine insufficiencies in the world here and there, but you know, but I also think it goes in line with the incidental tumors is that the numbers we used to quote when I started out in this game, which is a long, long, long time ago now, were based on really insensitive imaging techniques. And now that we have a marked increase in imaging and a marked increase in capability to find small tumors with these better resolution, I'm not sure the old numbers hold up anymore. So one of the questions for you, just start out is like, in terms of papillary thyroid cancer, is the incidence of it really going up, or is our ability to detect small lesions that we just didn't know existed before more the answer, or is it both? What do you think?
I definitely agree with you that imaging has increased our ability to detect these smaller cancers, but I do also think that the incidence itself is also increasing. So I do think the answer would be both, in my opinion. We definitely have come a long, long way with improvements in ultrasound and the quality of the imaging that we can get. And then in addition to that, with FNA biopsies, improved cytology metrics with pathology, more regulated protocols as far as how that cytology is called. And then really with the invention or advent of molecular testing, I think we've really advanced a lot in thyroid cancer management. And so we are detecting more, but I also think more and more studies are being done looking at other causes of increased thyroid cancer, like environmental toxins and those types of things as well contributing.
Yeah, and certainly some of the more famed environmental disasters, the Chernobyl types and things like that, they give people research material for several generations. But we'll figure that through. I mean, one of the things about writing exam questions and stuff is we give people these A through E choices or whatever. But in my experience, a patient rarely walks into the office or the clinic or anywhere with a multiple choice question pinned to their shirt. So usually you find out. So when you get somebody with a thyroid nodule that somebody either felt, which would make me happy considering how few people do physical exam in certain circumstances, or how many found it on some incidental imaging test, which seems to be more common. What's your approach to somebody who comes in with, for lack of a better term, a lump that is believed to be in the thyroid gland somewhere?
Well, for those patients, and I've definitely seen my fair share of both, for those patients, I think first and foremost, the most important thing is to obtain an ultrasound so we can better classify it. If they came in already, though, with imaging, like your incidentaloma, we already have that information. I think it's important to evaluate whether there are high-risk features on the imaging that they come with that push them more into a realm of being worrisome for cancer or not. And that usually guides my decision on whether or not I pursue additional workup for them. There actually are some good studies out there that demonstrate that the more we work up incidental thyroid lesions, it's actually causing harm in a lot of cases because incidental thyroid nodules tend not to be cancer. And so the large number of people have very, very benign thyroid nodules, and very few of them actually are in fact cancerous. And so if you look at autopsy studies and those types of things, the numbers are pretty high. And so I think the first thing is differentiating whether this is actually a nodule worth pursuing a workup for, or whether it's not. I think the other important thing for all patients with any thyroid nodules is also just thyroid function tests, similar to what we were talking about with the adrenal disease. It's important to make sure your thyroid function with, checking for your TSH as well, as well as your T4, making sure your thyroid isn't hyperactive in any way is important as part of the workup.
Yeah, I think it goes back to what's the structural and functional relationship? Is something driving the nodule, or is the nodule driving something, or is the nodule just there? I know that we have gotten certainly better now. Are you doing your own ultrasounds, or are you working with radiologists to do your ultrasounds? How's that working?
It's a little bit of both. Unfortunately, ultrasounds take up a lot of clinic time, and then also a lot of patients already come in with ultrasounds, and so I work closely with, at least at my institution, our radiology department, and they do the majority of our ultrasounds. I do always perform an on-table ultrasound prior to any operation I do, but typically just to keep clinic flowing a little bit better. However, we do have all the capabilities in our clinic. So if there's something that is questionable, or if we didn't have, great views on the ultrasounds, and even if I had radiology do my ultrasounds, I always make sure I review all of the images. So that's another important point, I think, is not to just rely on a report, but to review them yourself. Even if radiology does do them, I review them. And if there's anything concerning, I'm very low threshold to repeat it myself.
Yeah, I would say that every surgeon who I actually trust always looks at the images in person. And a lot of the disciplines that we work with tend to read reports. We tend to look at images, and I cannot emphasize enough how much you learn from looking at images. Plus, keep yourself out of a jam. But I would say that, and I don't know if this is your experience or not, but in my experience, of all the imaging modalities, ultrasound is the most operator dependent.
Absolutely.
So that's why whenever something really hinges on ultrasound, I know it screws up the workflow in clinic, but I tend to do it myself, or my partners who do their bit tend to do theirs. But certainly, if you've got a large enough volume in a team where you can distribute the workload, it kind of depends where you are. But I have found that a lot of ultrasound studies that are done simply don't answer the questions that I need answered. So are you doing that pre-op on everybody, or are you doing it intra-op as well?
I do it intra-op on anybody I operate on just to make sure there's nothing I'm missing. I think that what's important, so for one, I'm very lucky to have a great radiology team at University of Utah, and so I do trust most of their imaging.
Sure.
I think for thyroid cancer specifically, or thyroid operations, the real big question comes when discussing with the patient lobectomy versus a total thyroidectomy. That's something that Dr. Fields and his co-authors talk about and kind of walk through in the chapter. And I think for me, though, beyond that question, the really only other important part on the ultrasound that's important to me in deciding surgical management up front is lymph node status. And so that's one of the things I'm often looking for when I go through those ultrasound images myself, is whether or not I feel like they've adequately assessed our lymph node, our lateral lymph node basins. And so, that's really one of the only things in my mind, and Dr. Gillis might have a different opinion, but that's one of the big things that I look for on ultrasound. And as long as I'm satisfied with that, the assessment that I receive from the imaging, I still repeat it on table to make sure there's no growth or advancement. But whether the measurement is slightly off or the characteristics are slightly off, I rely a lot on my cytology results from my FNA or molecular testing to guide kind of how I counsel my patients anyways. And so, I think it's important definitely to make sure the images are adequate, but there are only so many things that I'm really looking for on them for the ultrasound personally.
Now, do you lead with FNA or do you lead with solid, core biopsy? Or what's your preferred start?
Yeah, I always start with an FNA. Especially the thyroidectomy used to be one of the deadliest operations because of how vascular it is. And so core biopsy, unless I have concern for something like anaplastic cancer or some sort of metastasis, my go-to is typically an FNA biopsy.
Okay. Now, it's said that if you live long enough, you see everything cycle around. And when I started out, when it came to endocrine work, the general mode was one of massive escalation, clear out sort of everything. And then Blake Cady and Ricardo Rossi were my mentors when I worked at Leahy Clinic. And Blake was a big proponent of sort of the de-escalation phase, and actually took a fair bit of criticism for that in his time. He's since been proven to be very much right. But I think as we're learning with a number of other tumors, in particular as we get more sophisticated in our medical management and precision medicine, if that term still is in vogue, that the goal of operative management is to get the maximum benefit with the least amount of mayhem. So what are your thoughts on sort of how do you decide go big, go small, sit tight, and follow along, and realizing that we'll probably get into the conversation about what does it cost to follow along and who's a candidate?
Yeah, I definitely agree with you that the tides switch a lot. And we are definitely currently in an era where we're minimizing the management and, like you said, doing more precise and dedicated, tailored management. For me, I think, one of the things that matters a lot to me personally is really the patient's perspective and, the shared decision-making aspect of deciding between a more aggressive or a less aggressive operation. The studies show, especially if somebody is high risk features, larger nodule sizes, any signs of more lateral disease or central neck disease, those are people I would definitely be more aggressive in. I think personally as well, younger patients give me more pause as far as, they have so many years to live. That I would, probably act in a slightly more aggressive manner just to make sure I clear disease if it's appropriate. But I think that there are a lot of patients overall that we can get away with less with. Since Dr. Mayuchi in Japan started all the active surveillance studies over a decade ago, we're seeing that, especially in micropapillary thyroid cancer, less than 1 centimeter tumors, that we don't necessarily need to operate on them and they are not necessarily growing. And there are definitely different criteria we apply for when we do decide to operate on those people or not. But back to what I was initially saying, I think that the patient factors and the patient's own well-being factor a lot into my decision making. Having trained in the South and then now practicing in the Mountain West, I have drastically different patient populations. And so, the basis of understanding the differences, the reliability of having access to the care they need to be able to follow, thyroid function labs after having a total thyroidectomy, that all plays into some of that. And I think that will be a really interesting discussion when we start talking about the last chapter we're going to talk about. But, I think that if a patient has struggles with being able to take a daily medication, I think it's absolutely appropriate to be less aggressive and do a lobectomy and try to save them the need to be on a lifelong medication that they require for their life, And so I think in those situations, that's where the patient opinion matters a lot to me, and just what their lifestyle is and what they're willing to tolerate. We always talk about you can't convince a smoker to quit smoking unless they're ready to quit smoking themselves. You shouldn't do a total thyroidectomy on someone if they're not willing to take a medicine every day of their life, and it's still a valid, board appropriate answer to do a lobectomy. I think that that's an important consideration.
No, I think you're right. And I think we will get back in the last chapter when we get back to the healthcare disparities. As another person who moved from the urban East Coast into the Midwest and then the mountain, much of the Pacific Northwest, the populated side and the non-populated side, there's a huge number of non-really medical factors that have to be taken into account to get your patients what they need. But sticking with you for a second, Jessica, if you don't mind, I think, we're sort of migrating our way into the neck and now off the side of the thyroids into the parathyroids. So we're going to take a little geographical tour of endocrine land. But there's a chapter written in here in the surgical management of secondary and tertiary hyperparathyroidism. Again, absolutely board's examiner darling questions. Written by Dr. Bartz Kuricki, I hope I'm pronouncing that right, in Dream. So just because we have listeners of markedly different skill levels, so give us the quick rundown on primary, secondary, and tertiary hyperparathyroidism to set the stage for our listenership.
Yeah, absolutely. So I always like to think about, really what those words primary, secondary, and tertiary mean. So for me, primary hyperparathyroidism is a primary disease of the parathyroid organ. So it's an overproduction of parathyroid hormone leading to an increase in your serum calcium. And so that's what I think of with your classical or your more primary hyperparathyroidism. Secondary hyperparathyroidism, I think of as secondary to some other cause. So the most common cause we think about with that is secondary to renal disease. So we see this most often in chronic kidney disease. And so with this secondary hyperparathyroidism, or renal hyperparathyroidism, as it's sometimes called, this dysregulation is due to your chronic kidney disease leading to a vitamin D deficiency, leading to your inability to actually absorb the calcium. And then tertiary is kind of tertiary to something. But oftentimes, I think when I at least was a trainee, in my mind, it was, this is after you've had a transplant and then you still have hyperparathyroidism. Well, that is true. The most common situation we see tertiary hyperparathyroidism is in the setting of end-stage renal disease after they've had a renal transplantation. But typically, what actually tertiary hyperparathyroidism is an end organ dysfunction or dysregulation because it's been subjected to the secondary cause of something for so long. So you've had this long-standing renal disease. It's impacted your body physiologically to the point that it's not even dependent on your renal function anymore. Your parathyroids grow and become so hypertrophied because of this long-standing progressive disease that it is autonomously producing and becoming a problem. And so that's typically how I see primary versus secondary versus tertiary disease. They're all kind of different scales along the same spectrum.
Well, great. So that leads me to the next, your last sentence. It goes on to create a problem. So now the question is how much parathormone is required to create a problem, and what problem is it that you don't want it to create? That's bad grammar, but if you follow the sentence.
Yeah, so it's a little different between secondary and between tertiary. For secondary, these are people that are going to have very, very high parathyroid hormone anyways, again, due to secondary to their renal disease. Currently, the guidelines recommend a referral for parathyroidectomy in secondary patients when they have a PTH level greater than 9 times the upper limit of normal, and also when they have other manifestations in their body of this high calcium level. So with secondary hyperparathyroidism, the most common would be calciphylaxis, refractory hypophosphatemia, extraskeletal calcifications, pruritus, and bone pain. And so these are kind of life-limiting or, really severe problems that these patients with secondary hyperparathyroidism can have. And so those are typically when we get recommendations for referrals for those. For tertiary, this one is actually evolving, and a lot of recent research has been done actually out of Dr. Gillis's institution at UAB looking at tertiary hyperparathyroidism. But these are patients that have either already had their transplant or they're awaiting a transplant, but are, again, autonomously functioning with hyperparathyroidism. Typically, we recommend that if a patient after a transplant still has elevated PTH, about 3 to 6 months after their transplant, they should at least warrant assessment by a specialist to evaluate whether or not they would benefit from a parathyroidectomy. Early referral, I think, is the key here so that somebody that's an expert and specialist can at least be discussing this with these patients, because the studies are now showing more and more that this avoids risk to the graft when you have earlier intervention on tertiary hyperparathyroidism. And then, for all of the patients, if they're to continue with their tertiary hyperparathyroidism, earlier intervention leads to a lot of benefits like cardiovascular and other medical comorbidities that they end up having.
So that leads me to a question that, let us say you've got somebody who's got end-stage renal dysfunction. I'm not sure we call them disease anymore. That goes around too. But their kidneys aren't working. They're being dialyzed. Say they're going to get teed up for a living-related donor. So you're not waiting just on the list. And they've got secondary hyperparathyroidism. Should you operate on them prior to them receiving a transplant, or should you wait and see how they do after they get a transplant? You know when they're going to get it. They're going to get it, or you can pick the time when they're going to get it.
Yeah, I think that is a bit of a difficult question for me to answer because I think the data would suggest multiple ways. For me personally, we definitely have had patients that come to see us for secondary in lieu of an upcoming transplant. I think it depends on how severe their hyperparathyroidism is to begin with. And then I also kind of think it depends, a lot of factors about the patient, back to patient-centered care, their age, their status, and as long as it's not something that would delay their ability to get their transplant ultimately, I am probably on the more aggressive side when it comes to operating on secondary and tertiary hyperparathyroidism. And so I would probably go and proceed with that. But you can definitely find, if you put 10 endocrine surgeons in a room and ask them that same question, I think you'll get 10 different answers.
Perhaps 11. It's been my experience. Don't feel bad. It's the same with pancreatic surgeons. We all have multiple opinions on everything, so you can't. It's not a 1-to-1 ratio, sadly. So, when would you? First of all, if you were going to try to manage somebody medically, and I realize that's up to the endocrinologist, not just you, but we surgeons tend to not completely delegate to anyone. It's our nature. What would you say would be the right medical management, and how would you decide that it is either suboptimal or just plain failing before you switch over to an operative strategy?
Yeah. So typically, I want to make sure I'm not misspeaking with what I'm labeling this. We typically use a calcimimetic, and Dr. Gillis can correct me if I'm incorrectly stating that. But we typically manage them with a calcimimetic. And so that would allow for the calcium to get back to kind of a normal level, and really allow for, you know, basically the management of the endpoint symptoms of the parathyroid disease. It doesn't actually treat the disease process itself. It just almost is like improving the symptoms that they receive due to the parathyroid disease. And so, I personally don't have a ton of medical management of these patients, but typically, we'll do the, calcimimetics, we'll do phosphate binders. Oftentimes we'll use calcitriol or vitamin D. And these are kind of, to me, in my mind, bandages in some ways. I think for secondary hyperparathyroidism, it does make more sense to have patients on medical management, because there is always the chance that they will be cured if they are lucky enough to get the transplant or to have their kidney disease reversed in some way. But for tertiary, I'm a strong person that believes that tertiary, if you're not improving after you've already had a transplant, you are much better off. And there are a lot of, back to that cost analysis and those type pictures, there's a lot of benefit in undergoing parathyroidectomy early for your tertiary hyperparathyroidism patients. So I would probably personally, and again, I'm very lucky to have a really great endocrine team of medical doctors that work with me in conjunction. But, and nephrologists, honestly, I work a lot with them on these patients. But I'm probably more likely to treat medically in a secondary hyperparathyroidism situation, and then more likely to be more aggressive with operations with a tertiary cohort.
Okay, sounds good. Now, let's say you get to the point where no matter what path led you there, you decided now it's time to consider operative management. Then the classic question people are going to encounter is going to be, I think, a series of them. Basically, to differentiate it between adenomas and hyperplasia with primary, you're into a whole parathormone axis problem, if that's not too vague. So now the question is, what should you do about imaging? What should you do about determining the number of glands? As we know, it's usually 4, but not always, and they're not always where you wanted them to be. How do you feel about gland resection, autotransplantation, intraoperative parathormone analysis? So the technical bits that people largely get asked about this. What are your thoughts on that?
Yeah, so that's a great question. I think that it's really interesting. Secondary and tertiary parathyroid operations are actually some of my favorite, because it's so satisfying, because oftentimes you have super enlarged 4-gland disease. And, as opposed to the opposite, where you have your mild primary hyperparathyroidism patients and you're, searching around for tiny little parathyroids. It can be actually very satisfying to operate on a secondary or a tertiary. So I'll kind of start through the process of how I think about approaching the operation for these patients. So your first question on imaging, I think that preoperative localization studies are always helpful in the way of knowing whether or not for 4DCT, you can roll any ectopic locations. However, I don't necessarily rely on them, and I don't necessarily always need them. I trained at a place that was very radiology minimizing. So especially for these secondary and tertiaries, we almost always know that they do have the 4 glands that are enlarged, and I would really not necessarily personally perform a minimally invasive parathyroidectomy in this population, just because I do know they're more likely to have 4-gland disease, even if the localization studies tell you there's one home run. Maybe I'll start by looking on that side, but my suspicion is that these patients will have 4-gland disease, and so I have a very low threshold to just do a bilateral exploration. The important thing for me, though, with imaging, and which is important for any endocrine surgery you do, is making sure that you don't have concomitant thyroid disease. And so for that reason, I would get an ultrasound just to make sure I rule out any thyroid nodules that need to be addressed at the time of a parathyroidectomy. And then, to your point on the 4-gland, like I said, most often it is 4-gland secondary I'm pretty sure it almost always is. Tertiary, I think you may have a situation where somebody actually does have an adenoma of some sort. And so for a secondary operation, I do tend to favor a subtotal parathyroidectomy. Your two options for surgery are both a subtotal parathyroidectomy, where you do basically a 3.5 gland resection, versus a total parathyroidectomy, where you resect all 4 glands and then you auto transplant a portion of one of them. I tend to favor subtotal parathyroidectomies just because the data favors that patients have lower rates of postoperative hypocalcemia and issues. One of the kind of major teaching points, especially for the trainees, I would emphasize for subtotal parathyroidectomy is that you want to be able to assess and look at all 4 glands first, and then you pick your remnant first and make your remnant before you resect the other 3 glands. The reason that's really important is if your remnant starts to die and that's the last thing you did and you've already removed all your other glands, you are then not in a great place, because then you will be at that point forced to do this total parathyroidectomy with the auto transplantation. So, I always teach my trainees that it's really important to look at your remnant and make sure that that's viable and going to function for you before you proceed with taking everything else. Similarly for tertiary, I would also typically do a 4-gland exploration. If I do find that some of the glands actually do appear normal, which I think would be more likely in tertiary, then I'm more likely to just selectively take the abnormal glands and treat it like I typically treat a surgery. But again, typically there are 4 glands that are enlarged in that situation. I think with your question of intraoperative PTH, I think that I don't really drive or lead my operation based on that number, but I do at least obtain it for an academic reason and kind of understanding how those numbers change. And then another kind of interesting topic that the authors also talk about in this chapter are, the concept of doing a cervical thymectomy. So you can actually have intrathymic parathyroid glands. And even if you don't have an intrathymic parathyroid glands, there are actually parathyroid rest cells within some of that tissue that can drive actually and continue to drive your secondary and tertiary processes. And so typically I do perform thymectomies on patients for secondary and tertiary. But again, you ask 10 endocrine surgeons, you'll get 11 opinions on that.
Yeah, I think one of the points made by the authors in the article is, at least with secondary and tertiary hyperparathyroidism, if you're going to check intraoperative parathormone levels, you have to be aware that the clearance kinetics are not the same as what you're used to with primary. And I would agree with you. It's been a while since I've done this kind of work, but I don't think in tertiary or secondary we would have been relying much on intraoperative parathormone levels to make our decisions. I think your advice about people not painting themselves into a corner by leaving the last gland to divide is absolutely something that people need to hear, understand, and internalize, because that's a mistake you'll make hopefully never, but if you do make it once, hopefully you'll never make it again. So that's one of those lessons learned, hold my beer, watch this moments. So we don't want to see that go on if people can avoid it. All right, I think we need to move on to our last chapter, which really sums up lots of different pieces, but to get back with Andrea, if we could. The article in here on healthcare disparities written by Doctors Ramirez, Nwariaku, Mu Young, and McMullen. So as I said, this would be a first for us, having one of our guest editors discussing one of the other guest editors' paper, but that ought to be lively. So Andrea, let's just start out with, I think we touched a little bit during the discussion about just the disparities that exist in general. Forget the patients for a moment. We should never forget them. They're always foremost. But we have massive dislocations in the distribution of healthcare resources for lots of different reasons. Urban places, suburban places, rural places, mountainous places. We've at least in the U.S., and I would say most of the disparities in this article refer to medicine in the United States. So we'll come back to that, I hope, towards the end of the discussion. But in your mind, we also have disparities within those subgroups. So give us the general overview of your thought on the disparities we encounter and how we set them up to analyze them.
Yeah, I think it's a huge topic, and Dr. Ramirez and her co-authors did a great job of condensing a lot of information down into bite-sized pieces. But their first description is about just what you mentioned, disparities in access to care. And endocrine surgery is a unique subspecialty, and a lot of our patients have these incidental findings. And so oftentimes they or their provider, or a variety of reasons, will sit on these findings and be slow to refer. And really, which patients get referred varies. And so a lot of that has to do with their geography. Is there an endocrine surgeon nearby? Do they have access to one without driving hours and hours? And unfortunately, a lot of that drives care and delays in care. And so, this first section is just that. Which patients are getting or referred later, and how is that affecting outcomes? And so they looked at that based off of things like insurance status, based off race and ethnicity, and showed that both malignant and benign disease subtypes, certain patients facing more of these systemic issues are later to present, and likely as a result of that have sort of these more severe outcomes, more metastasis, more recurrence, longer hospital stays, anything you could think of. And so I think this chapter is really important to kind of set the stage and what work really needs to be done, and to come up with more innovative solutions to try to reach these patients.
One of the things that struck me, and this is personal, I hate to be anecdotal, but having practiced in some of the most austere environments in the world, Iraq, Afghanistan, some other places that we were off on our own little missions, versus being in some of the most healthcare dense places in the world, like Boston, there's a lot of variation on what you have access to, no matter who you are. My other observation from having worked in a lot of different practice environments where I've had more than 1,000 doctors, I've been responsible for only a few. There's a wide variety of practice patterns among and within doctor groups, even in the same institution. Yeah. So institutional volume has always struck me as a challenging metric, because not everybody in the institution necessarily deserves the credit or the blame for what's going on in the institution. There's a distribution of capability usually within groups, but some of the population-based stuff I found, even where I am now in Eastern Washington, we're a few miles away from the border with Idaho. There's a marked difference in the patients and what they want and don't want who come in from Idaho. And then we have two university towns within 6 miles of one another. The people that live in the university towns approach life one way, and the people that live in everything around it is very rural. They approach life one way. And I'm not suggesting one's right, one's wrong, but there's a lot of factors that go into what patients want and what they're provided with that end up colliding in these differences in utilization of results. And in reading through this article, I was trying to sort out how we subcategorize the groups to get a better handle on those things. So what are your thoughts on that?
Yeah, I mean, I think that's a nice segue into this next section, is guideline concordant care. So we have guidelines for many things, but some things we don't, and some have already been brought up on this talk today. What exactly do you do when there's more clinical equipoise? But there are certain things that we try to stick to. So that ideally should settle out some of that practice pattern, some of those practice pattern differences, but we see that it doesn't. And so, and some of that I think does have to do with volume, even within a hospital. If people may not do a lot of, adrenalectomies or parathyroidectomies, they at least know who to send those people to if somebody is high volume within that system. Where it becomes a little more tricky is if you don't have someone who's high volume, if you haven't within your system or practice designated someone to be like, you are the parathyroid person. Then, people who do not think about this often get approached with these patients, and kind of the care gets a little bit more unpredictable. And unfortunately, there are certain patients who end up in those systems where there aren't high volume providers. It's not a high volume system. And they at times suffer because of that in terms of not getting guideline concordant care. So there's lots of different ways to divide it. A lot of like our big data banks don't have great data on things like ethnicity, age, insurance status. It's just kind of like billing information, which only kind of scratches the surface. So a lot needs to be done more to delineate, exactly who these patients are and how we can meet them where they're at and help them to get better care.
But we could spend hours on the limitations of the medical record in terms of actually improving patient care versus improving administrative function. And I'll say it as kindly as I can by that saying that. But we're gonna save that for another day, perhaps. We've all recognizing the brevity of life, we won't dig into that right now. But one of the things, one of my senior partners once said that the least utilized piece of technology in medicine was the telephone. And in my experience, with the, when I started, and again, not when I was at Boy Stories, but when I first started in medicine, everybody worked as inpatient and outpatient doctors. There was no such thing as an ambulist or a hospitalist. And certainly things have improved in many ways with the specialization and subspecialization. But one of the things that actually probably got worse was fewer and fewer doctors, even within a community, actually knew one another, because there was no mechanism for them to ever physically bump into each other. If you only work in your outpatient clinic and you never ever go to the hospital, your world becomes a pretty insulated bubble pretty quickly. Surgeons, I think, are still stuck with that. We see patients in clinic. Not stuck with. We're grateful to have them, but we have the opportunity to go to the OR, to go to the ICU, to go to the clinic, to go to the ER, go wherever you go. We sort of live in all environments still, particularly if you're doing a broader based version of general surgery. You're obligated to go to all these places. And so we run into a lot of people by nature, but doctors have become dissociated from one another. So I don't think they have an intuitive sense of who to pick up the phone and call. Like, I would love to call you if I had this problem, because you'd set me straight. Either of you, both of you, maybe both at the same time. Now you can call people multiple times on your iPhone or whatever you got. Don't want to make Google people upset, Android folks. But I think that we don't necessarily use our resources. And a number of years ago, John and I have been at this for a while, but I think in one of the forwards I wrote something stupid like we should suspend all R&D money for a year and take all the money and just spend it trying to get information out to people that we already knew. We shouldn't do it. I mean, don't get me wrong. It's hyperbole for the sake of point. But we have accumulated massive amounts of knowledge, and we are not getting the word out to people so they don't know that it's there. And it's kind of the tree falling in the forest scenario. So, I mean, you're both working in environments where you have a critical mass of people that everybody sort of knows about locally. But probably 90% of the healthcare that's being delivered out there, at least on the front lines, isn't in an environment like that. So what are your thoughts for how we fix the provider advice axis before we get to the patient access and financial access? What are your thoughts on that?
Well, that is a huge question. I think that the American healthcare system is struggling with writ large. Within endocrine surgery, I think, and probably within all subspecialties, I think our societies really need to take the charge. And the AAES, the Endocrine Surgery Society, has made things like databases so you can find a local endocrine surgeon based off of your location. They also publish guidelines that can be easily distributed, and they even publish things for endocrine surgery providers to go out into the community. And here is a package PowerPoint for you. just to be able to distribute information efficiently and not have to reinvent the wheel. So I think, and if I'm a medical provider and I type in American Endocrine Surgery, if I have some question, the society should be the ones to pop up. And I think that should be a great resource for people who are not really sure where to turn. Other than that, obviously training is really important. Getting more people willing to work in more austere environments, not just in the big cities. That's a huge barrier, both financially and volume wise, because you're training people to be high volume and they go into these rural places where they're not going to have that same high volume. So, I mean, there's a lot of creative ideas about tackling each of those issues, but I think really seeing them enacted is going to help with reaching as many patients who have these endocrine diseases as possible.
How many opportunities do you get? And I'm not trying to put you or Herb or anybody on the spot, but Herb's from Marshfield, where I used to run the show. He didn't work there. He worked at Madison, but we worked together when we were in Wisconsin. But how many opportunities do you get to get out of Birmingham and go out to the community and reach out to the people who otherwise would never have heard of you?
Yeah, I mean, we do try to do a fair amount of outreach. And I think, UAB has been very active about that, reaching out to these sort of smaller clinics in places with much smaller populations, places like Dothan, kind of places that, Alex City, the places that you can't even find unless you really zoom in really closely on Google Maps. And so I'm following their lead, have been really active about doing just that, reaching out to these rural locales to bring these patients in. It is often a trek for a lot of these patients. So we're pretty lenient about telehealth visits. Sometimes I only meet my patient IRL on the day of surgery. And I think that is something that, providers have to be pretty comfortable with if you really do want to try to reach these people. But with people coming from, the state line of Florida, from, Mississippi, where there's only really one academic center, but no endocrine surgeons. And so they unfortunately have to make the trek. And then, of course, with that comes a lot of the financial problems, getting prior authorization from all of the insurance companies. Yeah. So it's a huge overhead labor of love, but I think it's necessary.
Yeah. I think having worked on big policy and small one at a time patient work, as much as it doesn't seem it, I think it's easier to fix the big policy issues, because that's where you get government involved. And I mean, the federal government, in terms of, especially the Department of Defense, in terms of dealing with this military, is very, very good at getting the patients to the right places. Now, granted, they've got sort of an unlimited checkbook to do it. But they don't spend that much on medicine as people might think. But we get people, and those are things that you can put pressure on a small number of legislators, and at some point in the future, we will come up with better answers. So that's the arc, I think. To me, the bigger problem is our own community, because doctors only love being told what to do when they're telling somebody else what to do. They're not really very good at being told what to do when somebody's telling them what to do. They're rugged individualists at that point until their boss or somebody like me and telling somebody else to do this or that. And believe me, that doesn't work out as easily as people think. But I think, there's a number of layers of this that have to be straightened out. Medicine probably has a better chance on our level with working with other doctors. I don't know how to do that, though, in the modern framework. I don't know how to make the connections. You'd think it'd be easier, but I hope somebody smarter than I am and in your generation or behind your generation comes up with a more effective way of communicating in real time. The government stuff, America, as Churchill said, it'll always do the right thing after it's exhausted all the other options. So we can wait for that. But so we kind of talked a little bit about the population-based stuff, a little bit about the geographical-based stuff. How much of it do you think is just cultural? What people want from medicine versus what we think they should take?
That's a great question. It's definitely a huge percentage of patient decision making is cultural, but some of that is being able to understand the options being offered to you. So, we get into issues of health literacy, but also cultural competency. So, do you relate to the physician in front of you? Do you think they understand your problems and they have your best interest in heart? And, there's some things about like gender concordance leading to bias in referrals in the parathyroid space. So that's harder to deal with, but definitely I think education is, the first thing to say, hey, look at your patients with elevated calciums. What percentage of them did you refer? And kind of doing that self audit to say, can I identify that I have this bias in order to be able to approach it and fix it ideally. Sure. But that takes a huge amount of work, both on oneself and within their kind of patient outcomes and data. But I think that's also something that, societies could really take charge of.
Yeah. I mean, one of the things the pandemic brought out, at least in my observation, and this is personal, I don't want to put it on Elsie or anybody else's, there is a very wide distribution of trust in the medical system writ large. And I don't think that distribution of trust is necessarily uniform amongst all groups. So what are your thoughts on sort of cultural differences in trusting anybody in healthcare or the system at all?
Yeah, that's another tough one. And it's often hard to tease out when you're just meeting a patient for the first time too. But yeah, there's a long history of kind of atrocities of this country that have affected a variety of different groups of people. Lots of great books to read about that. And so, yeah, I think making sure you're on the same page with patients is number one. Most people don't want to see a surgeon. It's just the long and short of it. But being transparent about how you can really help them, really the pros and cons. And I think the number one thing that makes people feel distrustful is feeling like they're getting the wool pulled over their eyes. Something is being left out, or they're being misled because something is being left out. And so, really being clear about the goals of an operation. I show people their scans, their labs. I want everyone to make sure that we're on the same page. I take pictures of specimens when I take them out. I draw pictures for people in the clinic because we oftentimes take things for granted when we've been doing this a long time. And, I see a thyroid every single day of my life. It's different for people who are scared, who are unsure, and who are confused. Like they've never even heard of a thyroid. Like, why does it need to come out? So I think that's how I approach the trust issue. And really make sure that people feel like they're on the same team as me.
Oh, great. Is there anything you think we didn't cover on this? That was kind of where I got to. It's a huge topic, and we could spend days, weeks, months, years, probably.
Oh, I think you got it.
All right. Well,
our author would like to add anything?
Yes, Jessica, would you like to, do we miss anything discussing your chapter while you had to sit in silence?
No, you guys did a great job. That was a great conversation about it. I definitely echo, thoughts on the benefits of telehealth for sure. For me, practicing in the Mountain West, the registry Dr. Gillis talked about, the AAES Surgeon Finder. If you look for the state of Utah, Nevada, Montana, Idaho, Wyoming, the only provider nearby is myself and my partner at the University of Utah in that database. And so, it's something that we struggle with a lot and benefit from a lot, honestly, at the University of Utah is the opportunity to provide specialized care to these, 5-6 states. What's been great is we have an Intermountain kind of license sharing system where I can get a license for all 5 of those states with some caveats, but I'm able to practice in those states so I can provide virtual care to them. And so instead of my patient driving 7 hours for me to look at their ultrasound results and feel their neck, they just come for the day of surgery. We keep them locally at a hotel for the night after, and then they can go home. And so I think things like that, we have a very frontier mindset at University of Utah as far as expanding our borders and trying to provide the best cancer care we can across those states. And so it's both a privilege and, a real problem in the area because it's such a spread out area, and most of the rural surgeons that honestly are some of the best salt of the earth people I've met, and a lot of our trainees go out and practice in these rural areas. They have a hard time because they're the only person in a 4 mile radius dealing with whatever they're dealing with. So I think that's one of the things I've learned in my practice is, when someone's calling you in your transfer center just to ask a question or for help, it's because they really need it. And so you're the only person in the area that has some expertise on that. And it's really important to take time to help those people.
I will say this, that there was an article written when I was a resident. It was in Hiram Polk's magazine, the American Journal of Surgery. And the guy who wrote the article basically said that if you're going to go be the only surgeon in a rural area, it's better to do that at the end of your career than the beginning. And I kind of read that with like glancing interest, and then didn't realize that at the end of my career, I was going to be doing just that. And so I'm helping this organization out, or at least I think I am. I'll let them decide if I am. But I'm out there, and it is way better to be out alone or with limited resources when you've spent your career with all the bells and whistles and all the people around you to learn all their tricks for 35, 40 years. You're a lot more comfortable going off to someplace on your own than if you just out of training and you really don't have people, because I think that even when you do fellowships and training is great and everything, the day you become a staff person, your brain functions on a slightly different kinetic level when it comes to taking care of patients. And a lot of your surety that you had when you were in training is a little less stable when your name's on the spine of the chart, metaphorically, since it's all electronic now. And I think that everybody benefits from having people around to help mentor them, even when they're fully done with training, whatever that means. But you do get a different sense, and I would encourage all my colleagues that work in, the ivory towers and the hallowed halls. If you ever get a chance to go work someplace where you're go give it a whirl for a little while, see how it feels. And similarly, I would advise my colleagues who are out there in the one riot, one ranger lands where nobody ever looks at what they're doing. Go work in a big place and take all the phone calls and have the helicopter fly to you a couple of dozen times a day and see how you like being on the other end of that. So that and to me, that's the kind of thing that improves communication. But anyway, I really appreciate your time, your efforts, your writing, putting together the book, and the conversation. Thank you so much both for what you and your colleagues have done. Appreciate it.
Thank you for joining us for this Surgical Clinics podcast devoted to endocrine surgery. The 4 articles discussed, as well as 13 others, are in the August 2024 issue, Volume 104, Number 4. This series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter @Surgical Clinics, and you can find our podcast on most major audio streaming platforms, including Apple and YouTube. Visit theclinics.com for more details. Thanks for listening.